Okay, let's go ahead and get started. Welcome to Medicine Grand Rounds. It's a pleasure today to introduce two folks who are working very closely together to understand endurance training in the heart and vasculature, Dr. Bill Cornwell and Dr. Chris DeSouza. I'll introduce both of these folks to you, and then I'll turn it over to Dr. Cornwell for his remarks. Bill Cornwell is an assistant professor of medicine in the Division of Cardiology. He received his undergraduate degree from Ohio State University and his medical degree from Wright State University. He did his house staff training at the University of Michigan and his cardiology fellowship at UT Southwestern, where he focused on exercise physiology and advanced heart failure. He has focused his research efforts on mechanical circulatory support and exercise capacity. And his work is funded by the NIH, and he is a recent recipient of the Outstanding Early Scholars Program from the Department of Medicine. Dr. Chris DeSouza is a professor of medicine in the Department of Integrative Physiology on our Boulder campus at the University of Colorado. He received his undergraduate degree at the University of Toronto, his master's degree in exercise sciences from George Washington University, and a PhD from the University of Maryland, where he focused on exercise and applied physiology. His research focuses on the vasculature, endothelial biology, and function as it relates to vascular motor tone, endogenous fibrinolysis, and neovascularization. So I'm really looking forward to this talk today, and I'll turn it over to Bill to begin the seminar.
Okay, good afternoon, everyone. Thank you, Dr. Schwartz, for the kind introduction and for the opportunity to present and share some of my thoughts on this topic with everyone today. These are my disclosures for the presentation. When we think about exercise in the heart, there are three main areas that I want to focus on today. The first is to emphasize that not all exercise is the same. Exercise can exert differential effects acutely on the heart and vasculature depending on the type of activity that you engage in. And we'll spend some time talking about how what we call or what we refer to as static versus dynamic exercise, how that imparts differential hemodynamic responses that are very important to consider when counseling our patients or watching and trying to understand why people have difficulties engaging in normal activities of daily living. Number two, a commitment to exercise leads to important changes in structure and function of the heart, which in certain settings can give the appearance of a pathological state or an overt cardiomyopathy. And then finally, there are many positive effects of exercise, many of which we all appreciate. But there also are potentially a few negative consequences of overtraining that we'll discuss. So I'll begin with a clinical case. This is a 53-year-old man who's an avid exerciser who has an abnormal coronary artery calcium score. He has no past medical history, not taking any medications. He's very active. On average, exercises 8 to 12 hours per week, runs at least 8 miles per day. Pace averages about 7 minutes, 45 seconds. He also includes cycling into his workouts. He has maintained this level of exercise really throughout his adult life and has completed in over 25 marathons. Recently, he had gone to a health fair and had a CAC score, which showed his score was quite elevated at 800. And when we calculate his ASCVD risk score, it comes out to 5%. So I saw him in clinic and he obviously asked the question, what do I do with this CAC score of 800? And I'll just throw out here several options that we have to consider. We could tell him it's not safe to exercise with that much calcium in your arteries. We could treat him with aspirin and a statin. We could do further testing with either a stress test or take him to the cath lab and look at his arteries. Or we could do nothing and tell him it's okay to keep exercising. As we talk about sports, endurance, exercise, and athletics, I do want to point out that we recently opened up a sports cardiology clinic here on campus. And I'm very pleased to lead this effort along with a few other cardiologists and people across several different disciplines. But we focus this not just on athletes, but really every individual across the spectrum of health and disease, from professional athletes to recreational individuals, and then people who have ambulatory cardiovascular and pulmonary disease, and all the way down the line to individuals who have advanced heart failure, and even those who are supported with mechanical circulatory support devices, or LVADs. There are a number of things that we provide for these types of individuals, anything from establishing training zones. We provide preseason assessments. We help with risk stratification. A lot of these individuals, as I said at the outset, may have structural abnormalities, and it can be very tedious and difficult to try and delineate whether or not these individuals have a true cardiomyopathy, or are these just benign structural adaptations to a lifelong commitment of exercise. As we'll talk about, a number of athletes have issues with orthostatic intolerance, and we also provide recommendations for exercise at altitude, not only for people who are healthy, but people with cardiopulmonary disease like to go to the mountains, and there is a way that you can safely get individuals up to the mountains to enjoy everything that the mountains have to offer. If you're not safe about it, you can run into a lot of problems. So we provide a lot of counseling for people with cardiopulmonary disease who are wanting to exercise at high altitudes where you have reductions in available oxygen. And then finally, we also manage and treat patients with POTS, postural orthostatic tachycardia syndrome, and more recently, and very relevant to the COVID pandemic, the long haulers, or post-acute sequelae of COVID-19. So just to start off, as I said, there are different types of exercise which impart a differential aspect of hemodynamic responses depending on the type of exercise you engage in. Generally speaking, we divide exercise into two broad categories. The first is quote unquote dynamic, which we may think of as endurance or aerobic exercise, and that imparts a large volume load on the heart, which over time can lead to eccentric remodeling. The second extreme is what we call static, quote unquote, or isometric, maybe anaerobic exercise, and that involves a large pressure load, which over time can lead to concentric remodeling of the heart. If you look at this diagram here, this very nicely shows how your body responds to these two different extremes of exercise. If we look first at oxygen uptake, or VO2, you can see that there's a large increase in oxygen uptake with dynamic types of exercise, but minimal change for static exercise. If we look at cardiac output, or Q, or flow, in this graph here, again, you can see with dynamic exercise, there's a large increase in cardiac output. We don't really see a major change at all for static types of exercise. Stroke volume increases to a large extent with dynamic exercise, but again, no real change with static exercise. And if we look at blood pressure and the determinants of blood pressure, it's important to remember the overall equation for blood pressure. When the residents and fellows are following me on service, I remind them that this is one of the most important equations in all of medicine and physiology, and you really need to understand it because it explains a lot of human behavior on an outpatient basis, and also how we manage patients who are in shock in the intensive care unit. But blood pressure is the product of cardiac output and TPR or SVR. And what we can see here in both cases of dynamic and static exercise is that blood pressure goes up with exercise. But what is very important to remember is that the determinants of blood pressure are quite different. Again, cardiac output goes up with dynamic exercise, and you have a large drop in resistance during dynamic exercise. But during static types of exercise, blood pressure rises as a result of an increase in TPR, not cardiac output. This is a very nice graph, and I show this because it very nicely illustrates the different types of exercises that people commonly engage in. On the y-axis, we're looking at static, the degree to which there's a static component in the type of exercise you engage in. And then on the x-axis, we have the quote-unquote dynamic component. I put in circles here common types of exercise that are that people do here in Colorado and up in the mountains. And if we just walk through this, this is just to give you an idea. Low dynamic, low static components, that's things like golf, yoga, those types of things. High dynamic components, running. High static components, highly static components, rock climbing, weightlifting, those types of things. And then there are some types of exercise that are a very highly static and very highly dynamic. Those are things like rowing, canoeing, cycling. those types of things. So that in mind, just to spend a few minutes talking about the quote unquote athletic heart and what exactly that means. Well, there are a few hallmarks here that distinguish the athletic heart from a normal heart, certainly, and hearts that are pathologic or people who have overt cardiomyopathies. First of all, these individuals have a low heart rate. They also have a high stroke volume, and they typically have a low systemic vascular resistance. There are some structural changes as well that go along with the athletic heart. First of all, they're big. They have an increase in LV size or diameter, so there's more volume in the left ventricle. And they may tend to have left ventricular hypertrophy, and we'll talk about why that is in a second. But the combination of those two changes, the increase in volume and the increase in thickness, can lead to what we refer to in the cardiology world as either eccentric remodeling or eccentric hypertrophy. So why do they get LVH? This question comes up quite a bit, but the rationale for it is actually pretty straightforward. If you go back and just remember first year physiology and the law of Laplace, which basically says that wall stress is proportional to the pressure in the radius inside of a chamber divided by the thickness. So as people engage in a lifelong commitment to exercise and the volume in the heart goes up, the wall thickness may increase in response to that in order to normalize wall stress. Third, there are some functional hallmarks of the athletic heart. First, as I said, LV dilatation and LVH may be profound enough to mimic a pathological state, and it can be very difficult at times to distinguish whether or not an athlete is actually suffering from cardiomyopathies or if this is just a benign consequence or an adaptation of a lifelong commitment to exercise. We won't talk about sudden causes of death, but most people are probably aware hypertrophic cardiomyopathy is one of the main causes of death in young athletes. So this can be a very tedious process with a lot on the line, and we want to make sure we're right. That can be difficult to distinguish. But, and very importantly here, systolic and diastolic function are normal and may even be supernormal in the athletic heart. And this is the very nature of the athletic heart. Despite the appearance of a pathologic state, it is normal, both systole and diastole, and may even be supernormal. Now, I want to talk for a couple minutes about different types of exercise and dive into a little bit more about the differential effects that different types of exercise have on overall cardiac structure and function. So this is a very nice study, non-invasive echocardiographic assessment of LV structure among two different types of athletes. One were runners and two were rowers. And if you look at the VO2 max here, you can see that these individuals are very highly functioning VO2s in the 64 to 70 range. That is a very high level performer. If we look at LV and diastolic volume, wall thickness, overall LV mass, blue are the runners and green are the rowers. You can see that volume is perhaps slightly higher in the runners, but both rowers and runners have volumes that are well above normal. Wall thickness is greater among the rowers, and overall LV mass is greater in the rowers compared to the runners. And this is what forms the basis of eccentric remodeling or eccentric hypertrophy. So for those that may not be quite familiar with the term, runners have, again, a large amount of volume, which is eccentric remodeling, while rowers have both large volume and large thickness, and that's what we refer to as eccentric hypertrophy. This is a nice comparison just to give you an idea of how different types of exercise impart differential effects on overall heart structure and function. So again, people who engage in both highly static and highly dynamic types of exercise tend to have the biggest hearts. Those would be cyclers, rowers, and swimmers. You can see running, long distance running we're starting to get kind of in the mid-range of overall size of the heart. And at the opposite end, rowers, heavy weightlifters, they tend to have concentric LVH as opposed to large amounts of volume within their heart. So very nice depiction of how different types of exercise impart differential effects on overall cardiac structure and function. So to dive a little bit more now into the actual physiology of how the heart responds, and I apologize for people who don't really enjoy physiology much, but we need to take a deep dive into the Frank-Starling curve and also pressure volume loops for a couple of slides, because it really helps to understand why these hearts behave the way that they do. This was an older study, but very elegantly done, very nice, and explains a lot of the physiology here Invasive hemodynamic assessment of endurance athletes, again, very highly functioning, VO2 max of 68 versus non-athlete controls with a VO2 max of 40. First, if we look at Frank Starling curves, on the y-axis here, that's stroke volume or some metric of contractility. And then on the x-axis, we're looking at pulmonary capillary wedge pressure. A couple things you can see here. For any filling pressure on the x-axis, any amount of volume, so to speak, athletes have a greater stroke volume than controls. The second thing is that the degree of change in stroke volume or cardiac output with any change in filling pressure is greater than non-athletic controls. If we look at pressure volume loops, some very interesting observations that we see here, and we can talk about how you can generate these in the Q&A time if there's interest in that, but these are very informative when trying to understand pathology and mechanisms of functional impairment really across the spectrum of health and disease. But focusing on the athletes here, we can clearly see that the PV curve for athletes is shifted down into the rightward, which is generally a good thing. That means that these individuals have a much more compliant heart, and more practically speaking, for any given volume, filling pressures are lower. If you go to the opposite end of the spectrum and think about somebody with HFpEF or heart failure with preserved ejection fraction, for any given change in volume in the ventricle, their pressures skyrocket, versus an elite athlete, any given change in filling pressure, or volume rather, leads to very small changes in filling pressures within the left ventricle. So chronic volume loading associated with endurance exercise increases ventricular compliance, which very favorably alters the pressure-volume relationship of the athletic heart. But there are a couple practical considerations from everything that I've just shown you here. First, the result is that you have an enhanced delivery of blood to exercising muscle during exercise. The second thing is, as I said at the outset, a lot of athletes have issues with orthostatic intolerance. If you go back to the Frank Starling curve on the left here, and just start in the middle at a wedge pressure of 10, if stroke volume increases in response to an increase in volume loading, you have a large increase in stroke volume compared to the non-athletic control. But at the opposite end of the spectrum, if you reduce your filling pressure or volume, for example, if you just go from rising to standing, we've probably all experienced that at some point. You rise too fast, you get a little bit of lightheadedness. That can be quite accentuated in an athlete to the point where they actually feel like they may pass out, because you have these marked reductions in stroke volume and cardiac output whenever your volume decreases, such as going from sitting to standing. More on pressure volume loops, but this is very informative data. Exercise really should be a part of everyone's life if you want to age gracefully, and this graph very nicely shows that. So what was done here is healthy individuals who on average were about 70 years old were stratified according to the amount of exercise that they engaged in throughout their life. And then pressure volume loops were created, and they were stratified according to the exercise that they did. So sedentary in blue was less than 2 sessions per week, casual 2 to 3 sessions, committed quote unquote exercisers were 4 to 5 sessions per week, and competitive individuals were those who exercised really every day of their lives throughout the entirety of their adult lifespan. And what you can see, again, just as a reminder, shifting down and to the right is a good thing. It means you have a more compliant heart. And what we see here is that routine exercise throughout life leads to a more compliant heart, which is obviously a good thing, which improves exercise capacity in your later years of life, having the appearance of a youthful heart in comparison to normal healthy aging, which otherwise leads to stiffening over time. The second thing to emphasize is that the heart has a high degree of plasticity. So we do have natural stiffening in the left ventricle that occurs over time, but it is possible to reverse that if you begin an exercise program. So this was a very nice study that was done a couple years ago, and I had really the distinct pleasure to be a part of this. But what was done here was 53-year-old, on average 53 years old, individuals who were sedentary, had not exercised before, began a 2-year exercise program. Again, back to the pressure volume loops. We look at baseline. You can see in the dashed line where both the controls and the exercise group, where their pressure volume curves were. But what we saw is that after 2 years of exercising, we actually improved ventricular compliance, which demonstrates that the left ventricle retains a high degree of plasticity well into the midlife. Exercise exploits this phenomenon, improves compliance, and allows you really to age gracefully. This also shows that it's never too late to begin exercise. We have, again, people here who are in their mid-50s, never exercised before, began an exercise program, and we're able to show that you can really impart a high level of plasticity in the left ventricle. So I always remind my patients it's never too late to begin an exercise program based on those very nice data. Well, what happens to the right side of the heart? Some very interesting data here. These are from the Australian group, which really are the world's experts in right ventricular function and physiology during endurance exercise. But they took competitive athletes and looked at cardiac MRI before and after an endurance type of event. And this is just looking at a quick depiction of changes in volume. And you can see that really there weren't any substantive changes in left ventricular volume. But on the right side, we can see that the volumes increased pretty dramatically. And if you look at metrics of RV systolic function, they decline following completion of the event compared to baseline. RV ejection fraction drops, fractional shortening declines, et cetera, et cetera. So following completion of an acute endurance event, we see increases in volume and reductions in systolic function. And it appears that the degree of RV dysfunction tracks pretty closely with the intensity of exercise. So people who do ultra marathons, 11, 12-hour events, they have a much greater reduction in RV function. But somewhat reassuringly for those of you who may do these types of exercises, it does appear that this is not permanent. On average, it looks like RV dysfunction normalizes or improves within a couple of days following completion of the event. We have taken some of these data to try to understand more about how the overall heart behaves during exercise, and more specifically, the right ventricle. This is a quick video of a study we're currently doing in my lab right now. And to the best of my knowledge, this is the only time in the world that something like this has been done, where we have an individual completing an invasive 180-kilometer cycling event with catheters in their heart so that we can in real time generate pressure volume loops to better understand really the limits of human performance and the degree to which RV function declines over time during an actual event. And I'll show you some preliminary data here. These are just the first 4 hours, so up to 90 kilometers in this particular individual. And you can see how these pressure volume loops change over time. But for people who don't really think about it that much, really the greater the width of the pressure volume loop, that means your stroke volume is going up. And we can clearly see from rest to 1 and 2 hours, there's an increase in the width of the pressure volume loop. So stroke volume and cardiac output have gone up. But what you can see, if I just focus your attention down to around 3 or 4 hours, is that we start to see reductions in stroke volume, and that is met with an increase in heart rate in order to try to compensate and maintain the same cardiac output as exercise increases over time. Again, more evidence, preliminary evidence, just to show that over a period of time, the right ventricle begins to become dysfunctional in the middle of an endurance event. So talking about some of the positive aspects of exercise, this perhaps is not unsurprising, but there are very nice data to show that a lifelong commitment to endurance exercise is associated with improvements in overall survival. So this was a nice meta-analysis of over 40,000 patients looking at different types of survival or death, overall mortality, cardiovascular death, cancer-related death, and across the board, you can see significant reductions in different types of mortality and overall mortality among people who are endurance athletes. Data from the French group, the Tour de France versus French populations, overall mortality significantly lower among athletes who competed in the Tour de France versus the overall population of France. And then if we look at specific causes of death, whether it's cancer, cardiovascular, respiratory, or digestive system, across the board, it would appear that exercise imparts a benefit when we think about survival. So what do I tell people when we think about exercise overall? The first thing is there really is no threshold. Do something. You can see on the y-axis here the reduction in mortality. If you go from doing nothing, just a simple exercise, you significantly reduce the risk of mortality overall. And there actually have been data to show that even standing up for 2 hours a day leads to around a 10% reduction in cardiovascular mortality. It appears that this starts to level off around 8 met hours per week of exercise, which comes around to about 150 to 300 minutes a day or per week of exercise. And at the extreme, there really doesn't appear to be a risk as long as we're talking about mortality with increasing the intensity of your exercise program. Putting fitness into its place, very nice data that was published in JAMA a couple years ago. Over 120,000 patients were followed for 8 years. And if we look at different factors, smoking, CAD, diabetes, renal disease versus low fitness, if you are not fit or the less fit you are, that actually increases your risk of mortality more than smoking, CAD, or renal failure. And that actually caught a lot of press attention and was discussed on CNN, which you can see here, but very nice data to reinforce the importance of exercise. Interestingly, and this is what really scares the athletes, is this what appears to be a U-shaped association between exercise and atrial fibrillation. And you can see that very nicely here, where generally speaking, if we go from doing no fitness at all to modest amounts of fitness, you can see a reduction in atrial fibrillation risk, but that tends to go back up on a U-shaped curve, such that highly active individuals may be at a higher risk of atrial fibrillation. As I said at the outset with my case, some individuals may actually have high levels of plaque or coronary artery calcium. These were nice data showing that athletes may have twice the amount of plaque compared to non-athlete controls, but it appears that the majority of these plaques are calcified. And interestingly, in this particular analysis, the number of years that somebody trained really was the only variable that was associated with a high level of CAC. So that begs the question, is high levels of coronary calcium unsafe in an athlete? That was looked at in this study, very nicely done. This were 21,000 patients from the Cooper Clinic who were followed for 10 years, and they were stratified according to the degree to which they exercised over time. Just to give you a frame of reference, if you follow the basic guidelines, 150 minutes per week of mild to moderate exercise, that comes out to around 500 nets per week. So these are very highly functioning individuals. But what you can see, if we stratify the overall CAC scores according to fitness level, first of all, these are very high, on the order of 700 to 800 Agatston units. But if we look at the actual outcomes, all-cause mortality or cardiovascular mortality, they actually were lower among individuals who had the highest CAC scores and exercised the most compared to the referent group. And if we look at individuals with any CAC, 1.0 or above, again, we can see reductions, non-significant reductions, but at least no signal of harm for overall mortality for individuals who, again, exercise to high levels and have very high levels of CAC. So back to the case, ongoing discussion that we had regarding the risks and benefits of exercise versus starting a statin. His preference was not to initiate therapy with statins and just maintain an active lifestyle. I pulled this one section out from an editorial on that paper that I just showed you, and it says very nicely here, the key question addressed in the present study was whether the presence of high calcium associated with high levels of exercise, as typically practiced by masters marathon runners, is associated with greater mortality. And for that question, the answer clearly is no. So this is actually quite freeing and allows you to at least have the discussion with patients as to whether or not you should start a statin and aspirin or just continue exercise, because it appears that it's probably safe. So in closing, a few summary statements, and then I'll turn it over to Chris. As we said, the acute hemodynamic response to exercise differs according to the type of activity you engage in. Athletes with the biggest hearts are those that engage in highly static and highly dynamic exercise. We talked about rowing, swimming, cycling. Athletes operate on a steep portion of the Frank-Starling curve. That allows for a large increase in stroke volume during exercise, but may also predispose to orthostatic intolerance, which is very common among these individuals. RV dysfunction may occur acutely during exercise. I showed you some preliminary data from our lab that very nicely shows that with pressure volume loops. The severity of dysfunction increases in proportion to the duration of exercise. Endurance exercise may predispose to AFib and high CAC scores, but it does not appear that CAC actually increases the risk of mortality in these individuals. And then finally, a lifelong commitment to exercise preserves ventricular compliance and may be associated with a reduced mortality. With that, I will stop and thank you, and I will turn it over to Chris.
Great. Thanks, Bill. I will.
Chris is getting set up. Let me remind everyone to add questions to the Q&A box. We'll be having a discussion after Chris's presentation.
Okay, great. Thank you, David. So I've been charged with the vascular portion of Grand Rounds today, and what I'm going to do, if I can move forward here, I'm going to narrow that down, and I'm going to focus specifically on the vascular endothelium. And this is critically important because the vascular endothelium plays an important role in cardiovascular health and in cardiovascular disease. In fact, endothelial dysfunction occurs long before any clinical evidence of disease, and it is certainly omnipresent during the latter, more clinically relevant areas that we see here regarding fibrous plaque and then the complicated lesion and rupture. Now, within endothelial dysfunction, for today specifically, I'm going to be focusing on endothelium-dependent vasodilation and endothelial-mediated vasoconstriction, and how exercise, regular aerobic exercise, favorably affects both of these two important characteristics of endothelial function. So today, regarding the benefits of endurance training, I've chosen to talk about three very diverse but important areas and important conditions. I'll first talk about aging, and then I'll switch rather dramatically and talk about individuals living with HIV-1 because of their high risk of cardiovascular disease. And then I'll finish with something that we're all quite familiar with, and that's insufficient sleep. And I'll focus on each of these with respect to endothelium-dependent vasodilation, endothelial-mediated vasoconstriction, and then show you the very nice and consistent benefits that you can receive via regular aerobic exercise. So just to give you a little bit of cell biology here and what we're going to be looking at, there are two primary endothelial vasodilating substance and a very specific vasoconstricting substance that we pay close attention to. And on the vasodilating side, this is nitric oxide. And nitric oxide is produced by the conversion of L-arginine through endothelial nitric oxide synthase to produce nitric oxide. It will diffuse to the vascular smooth muscle, and this will induce relaxation, and the blood vessel will dilate. Now, conversely, the endothelium also produces endothelin-1. This is a very, very potent vasoconstricting agent. When ET1 is produced in the endothelium, it can be released both into the bloodstream, but primarily ET1 is released abluminally towards the vascular smooth muscle, where it preferentially binds to the ETA receptor, and then this will induce vasoconstriction. Now, one of the relationships I want you to keep in mind here is that if you increase the amount of nitric oxide that the endothelium is producing, it blocks ET1 production. And conversely, though, if the endothelium is under more of a vasoconstrictor tone, more of a vasoconstrictor influence, and the production of ET1 is elevated, this in turn blocks eNOS and reduces nitric oxide production. So as I go through explaining and demonstrating to you the beneficial effects of exercise on both of these two important processes, the main thing to keep in mind here is this relation between nitric oxide and endothelin-1. So how do we measure vascular function in a conscious human? So all of the studies that I'll be showing you today involve intra-arterial infusion of specific vasodilating agents. This allows us to pharmacodissect what is happening and what's driving either the vasoconstriction or the vasodilation. And the way in which we do this is that we catheterize the brachial artery, and then this will allow us to infuse various vasodilating agents. And once that happens, then we can measure forearm blood flow using venous occlusion plethysmography. Now, the measurement of forearm blood flow in the forearm is quite descriptive. It provides us an excellent surrogate of what's happening in the coronary circulation. So in the forearm, there is minimal to no disease. So any impairment that you observe in the forearm to a given vasodilating substance, it is probably underestimating what is happening in the coronary circulation. So this model is extremely valuable and is extremely sensitive in determining endothelial vasomotor function. With all the studies that I'll be presenting today, the level of endurance exercise training is very, very moderate. And as Bill has so nicely described earlier, it doesn't take much to elicit important both cardiac and vascular adaptations. So all of the studies I'm going to be describing to you today involve this type of exercise intervention. They were all 3 months home-based aerobic exercise training programs. So we asked all of our participants to exercise on their own at home. Their exercise prescription we asked them to walk 5 to 7 days per week, at 65 to 75% of their maximal heart rate, and to do this for between 45 to 55 minutes per day. So we sent them home with a polar heart rate monitor. We taught them how to use it. As you can see here, it's wrapped around this gentleman's chest, and the signal is sent to a watch. We'll program their watches based on their maximal exercise test. So the watch will either beep if they're going too slow, if their heart rate isn't high enough, or it'll beep if they get above their certain heart rate. So what I'd like to really drive home here, and is for all of us to recognize, is this is a moderate aerobic exercise training program that can be completed by most, if not all, adults who are normally ambulatory. So it's not requiring any of this HIIT type training or cross training or going to a gym. All we really simply did was ask these individuals to walk for us on a daily basis. Here's the overall or consistent findings from this type of exercise training program that we've now instituted successfully for well over 20 years. Here again is the exercise prescription, 5 to 7 days per week, 45 to 55 minutes per day, at 65 to 75% of maximal heart rate. So this is a exercise prescription that certainly one could give clinically to any patient who is normally ambulatory, and they can successfully complete it. Here's the adherence. Overall, the participants walked 5 days per week. So we asked for 5 to 7, not 3 to 5. We asked for 3 to 5, you'll get 3. We asked for 5 to 7, and we got 5. On average, they walk 50 minutes per day, and at 71% of their maximal heart rate. Now, what are the cardiorespiratory effects of this type of training? Well, given the moderate nature of this aerobic exercise, VO2 max will not change. And the purpose here with this type of exercise program was not to improve VO2 max. If we wanted to improve VO2 max, then the training program would have been completely different. But importantly, maximal treadmill time to exhaustion increased by roughly 25%. Submaximal heart rate at any level, 60% of max, 75% of max, 80% of max. In this case, this is 70% of maximum, was significantly lower. And their submaximal ratings of perceived exertion is also significantly lower. So these are all indices, quantitative indices, that the exercise program induced cardiorespiratory adaptations. So once again, a very moderate aerobic exercise program inducing these types of cardiorespiratory adaptation. So the first study population I want to discuss is, or the condition is aging. And this is very nice data from Stefano Tedai's group in Italy back in 1996. And they're the first to demonstrate significant age-related declines in endothelium-dependent vasodilation in both normotensive men and normotensive women. On the y-axis, this is the forearm blood flow response to acetylcholine. Acetylcholine is an endothelium-dependent vasodilator. So this is very similar to what I just described. They catheterized the brachial artery, infused in acetylcholine. And as you can see here, across age, there's a linear decline with the ability to vasodilate to acetylcholine in men, as well as in women. The decline in women here occurring right around the time of menopause, but the slope of the decline after menopause is similar to men. So with these data in mind, we asked a simple question. Well, can exercise improve endothelium-dependent vasodilation in older adults? And the first thing that we did, this is cross-sectional data from the very first study that we conducted many years ago now. And we compared older sedentary men to older endurance trained, both men and women. And this is the forearm blood flow response on the y-axis to increasing doses of the endothelium dependent vasodilator acetylcholine on the x-axis. And as you can see, the older endurance trained adults demonstrated a 30 to 40% higher vasodilator response to acetylcholine than did the older sedentary adults. So these men and women were matched for age. And the only main difference between the two was their level of physical fitness. So in both men and women, the older sedentary adults demonstrated significantly higher vasodilatory responses to acetylcholine. So this provided the rationale then to do an exercise intervention and see if we can improve endothelium-dependent vasodilation in these older sedentary adults. So I'll show you first I'll show you the data in men. So we recruited some older sedentary adults. In fact, they were the same folks that I showed you previously. And they participated in that 3-month home-based aerobic exercise training program where we simply asked them to walk every day for us at their specified intensity. After the 3 months, there was a significant increase in the vasodilator response to acetylcholine. And in fact, if we overlay, here's some young adults, and you can very nicely see here that after only 3 months, and this goes back very nicely to what Bill says of it's never too late to start to exercise. After 3 months of aerobic exercise training, the vasodilator response in these older adults was quite similar to young, healthy adults. Now, there's been some discrepancy in the literature whether or not the same types of training effects are observed in postmenopausal women. And using this technique, we see a 25% increase in the vasodilatory response to acetylcholine in postmenopausal women after the training program, indicating similar vascular endothelial benefits to the exercise training program. And when you compare that to young premenopausal women, 3 months, again, of moderate aerobic exercise has improved their ability to vasodilate to a level now that's quite similar to young premenopausal women. Now, the flip side of the coin is vasoconstriction. And this graph shows the age-related increase in endothelin-1 mediated vasoconstrictor tone. So let me just walk you through this slide very, very quickly. This is the change in forearm blood flow to the ETA receptor agonist, BQ123. So the idea here is if you block the ETA receptor, remove that ET1 mediated vasoconstrictor influence, the vessel will then relax and passively dilate. And the more dilation you see is directly proportional to the level of ET1 mediated vasoconstriction. And as you can see here, when you block the ETA receptor in the young adults, there's very little change in forearm blood flow, indicating that the vessel is not under much ET1 mediated vasoconstrictor tone. However, in the older adults, when you block the ETA receptor, there's a 35 to 40% increase in blood flow into the vessel. This is indicating that with advancing age, you're under greater ET1 mediated vasoconstrictor tone. So now the question is, does regular aerobic exercise reduce this level of vasoconstriction? And it certainly does. So down below, and I'll show you data in men and women who participated and completed the same moderate aerobic exercise training program that I've described to you. And in the men, After exercise training, shown here in black, you see a significant reduction in the blood flow response to BQ123. And you see a similar significant reduction in the blood flow response to BQ123 in the women, indicating that regular aerobic exercise has reduced ET1-mediated vasoconstriction that occurred with aging. So in summary, with respect to aging, regular aerobic exercise can prevent and reverse age-related endothelial vasodilator dysfunction. Let's move on now to HIV-1. You may be wondering, well, wow, that's a pretty big jump. Well, individuals living with HIV-1 are at 3 to 4-fold increased risk of cardiovascular disease. In fact, these individuals are primarily going to have greater morbidity and mortality coming from cardiovascular disease than they're going to have coming from AIDS, especially in the Western world. And endothelial dysfunction is a key underlying factor. Indeed, this is data that we collected along with Elizabeth Connick, demonstrating impaired endothelial vasodilator function to acetylcholine in HIV-1 seronegative compared with seropositive. So it's about a 30% reduction in the ability to vasodilate in the HIV-1 seropositive adults. And if you look at area under the curve, which is what I'm showing here, this is the blood flow area under the curve to acetylcholine. It's about a 40% reduction in the ability to vasodilate, or the amount of blood flow in response to acetylcholine. So again, now the question is, can we repair this with exercise? And we certainly can. So again, this is the same exercise training program that I've described to you before. Now in these people living with HIV-1, after exercise training shown in black, there's a 35% increase in the forearm blood flow response to acetylcholine. And when you look at the total blood flow, total forearm blood flow to acetylcholine, we see similarly a 40% increase in blood flow. Both of these showing very nicely an increased ability to vasodilate after the exercise training program. Now, there was no change in the blood flow response to sodium nitroprusside. Sodium nitroprusside is an endothelium-independent vasodilator. It's a nitric oxide donor, causes the vascular smooth muscle to relax. There was no effect of exercise training on the blood flow responses to sodium nitroprusside, indicating and providing further evidence that these changes here are all endothelial mediated. Now, what are the mechanisms that could be driving this? And again, the primary endothelial mediating agent is nitric oxide. And when we measure nitric oxide bioavailability, or the contribution of nitric oxide to vasodilation using this type of model, is to block it. And we can infuse in Ng-monomethyl L-arginine. This is a specific inhibitor of endothelial nitric oxide synthase. So before exercise training, when you co-infuse acetylcholine with LMMA, so we're blocking eNOS activity, there is no reduction or change in the forearm blood flow response, as you can see with the blood flow response across each dose of acetylcholine or in area under the curve. And this is an indication of nitric oxide bioavailability, or the contribution of nitric oxide to the vasodilator response to acetylcholine. And when we block it pre-training, there is no change, indicating that there is very little nitric oxide that's being produced or that's available. However, after the training program, when we saw this big increase in the ability to vasodilate, when you block eNOS, there's a 30% reduction in the forearm blood flow response with acetylcholine, indicating that the increase in vasodilation in response to the aerobic exercise training was due in part to greater nitric oxide bioavailability. And nitric oxide is a huge anti-atherogenic molecule. So this is, from a vascular perspective, this is an excellent adaptation. So to very quickly summarize these data in individuals living with HIV-1, and that is that regular aerobic exercise improves nitric oxide mediated endothelium dependent vasodilation in people living with HIV-1. And now the final area to finish up is insufficient sleep. This is something that we are all very familiar with. And insufficient sleep is defined as sleeping less than 7 hours per night, and is now recognized to be an independent risk factor for cardiovascular disease. Sorry to be the bearer of bad news. Endothelial vasomotor function is markedly impaired with insufficient sleep. Indeed, this is recent data from our group demonstrating this very profound impairment in vasomotor function. So the upper panel is the vasodilator response to acetylcholine, the forearm blood flow response to acetylcholine. In the normal sleep group, so these are all middle-aged adults, they slept on average 7.5 hours per night. In the short sleep group, this is the group that habitually slept approximately 6.2 hours per night. And there's a 25% lower ability of the vascular endothelium to support vasodilation in response to acetylcholine. And to top it all off, when you look at the ET1-mediated vasoconstrictor tone, the individuals with short sleep demonstrated significantly higher ET1-mediated vasoconstriction compared with the short sleepers. So insufficient sleep is associated with reduced ability to vasodilate, increased ability for vasoconstriction. Well, what can exercise do to this? So on the left here, this is the blood flow response to acetylcholine, and after 3 months of moderate aerobic exercise, the ability to vasodilate in response to acetylcholine was significantly improved in the short sleepers. Now, I will say that these improvements are seen without any changes in sleep duration. So after the 3 month period of time, these participants did not increase the numbers of their habitual sleep duration per night, but they are now physically active. Accompanying this increased ability to vasodilate, there was less ET1-mediated vasoconstrictor tone after the exercise training program compared with before the exercise training program. Now, what's very nice to see, and I'm ending on a good note here, is that the improvement in acetylcholine seen with only 3 months of aerobic exercise training is now very similar to what was observed in the normal sleepers. So increased ability to vasodilate and the reduction in ET1-mediated vasoconstrictor tone is now on par with what was observed in the normal sleepers. So endurance exercise training can counteract endothelial vasomotor dysfunction associated with insufficient sleep. So for those of you who are not sleeping very much, if you're exercise trained, this will help you. Finally, here's the big thing for me to end. The vascular benefits of endurance exercise training. It is a silver bullet. I've only shown you 3 different conditions and populations. No matter what the population we study, regular endurance exercise training improves both cardiac and vascular function. With that, I'll end and turn it back over to David to moderate the questions.
Chris and Bill, thanks for 2 great presentations. So Chris, talk a little bit about the vascular bed outside of the heart. So what about the brain and other essential organs? How does exercise affect the vascular bed and these other organs?
So there is very nice data from a brain perspective that it does improve the ability of the brain to handle increases in blood flow. It improves the ability of the vasculature in the brain to be more resistant to both thrombotic as well as thrombotic stroke as well as with aneurysms. It helps to prevent dementia. It has definitely effects on dementia. So from what, it's very difficult to hone in as we've done here with the brain, but all indications that the vasculature in the brain will also adapt quite nicely to endurance exercise training.
Good. Bill, you talked about a little bit about some of the adverse effects of exercise training. as it relates to atrial fibrillation, um, maybe as it relates to right ventricular scarring, and also potentially as it might be associated with, not causal, in terms of CAC scores. I was wondering if you could talk a little bit more about each of those. So what, what, what's the hypothesis of how this is related to atrial fibrillation?
Sure. Yeah, first of all, that's not known, but the thought is that there can be structural remodeling such that the left atrium dilates and that predisposes to atrial fibrillation over time. There also may be inflammation, both acutely and chronically, depending on the type of exercise engaged and, again, the intensity. And I have to say, taking care of a lot of these people, some of these people put themselves through some unworldly types of lifestyles, which can impart a pro-inflammatory state. And part of that is thought to contribute to some of these types of adverse things like atrial fibrillation and then the high levels of CAC. Fortunately, based on the data, it looks like the CAC are stable and not unstable. So as I showed, those, for the most part, are less likely to rupture and cause an acute coronary event. But again, with the structural remodeling, the inflammation, the high degree of flow and shearing forces that may lead to higher CAC scores over time.
And you think that some of the right ventricular scarring may be due to dilation as well?
Yeah, so that's an interesting thing. The RV is a thin-walled structure. Left ventricle is a centimeter, give or take. RV is 3 to 5 millimeters, and it wasn't really designed, so to speak, to handle a chronically elevated load. When you exercise, your pulmonary arterial pressures go up, which means RV afterload goes up, and the RV can only sustain that for so long, and that's what we see in those studies where you get RV dysfunction over time. And then there are data, which I didn't really show in the interest of time, that you can get some scarring, particularly at the hinge points of the septum, so kind of where the septum inserts into the left ventricle. What's the significance of that? We really don't know, but you don't really see a lot of athletes with that scarring with a high level of VT or NSVT. So we see it. What's the significance? Not really sure.
Chris, you looked at gender, sex as it relates to response, and you show that men and women have a similar response to exercise training. What are the differences in the response to exercise training as it relates to gender or race or even genetics? What's known about that and what's being studied?
So the gender question is an interesting one. Depending on, there is a bit of controversy regarding whether postmenopausal women can derive the same vascular benefits as men. And I think the differences there relate to the methodologies that's being used. Most of the studies not showing an effect have used flow-mediated dilation. So they're looking at ultrasound measures of the brachial artery. So there's an important distinction there. That measurement is looking at changes in conduit artery diameter. When we infuse these vasoactive agents in, we're really looking at what's happening at the microvasculature level. So I think that may help explain some of the discrepancies that may exist with the effects of exercise between men and women. With respect to race, there has not been a lot done in that. The effects of exercise the beneficial effects of exercise are still there if you look in the African American population or if you look within Hispanics. Now, the mechanisms that might be behind that may be completely different. There are different mechanisms that certainly play a role in the endothelial dysfunction that's been observed in African Americans, for example.
Anything known about the genetics of exercise?
In short, not much. There hasn't been studies really looking at the offspring of people who have been habitually active for across their lifespan. And that's sort of the question that we'll have to look at. You know, it's interesting because if you look at the offspring of people with hypertension, the kids of parents of hypertension have endothelial dysfunction. And that sort of begged the question of what comes first. Is it the hypertension driving the endothelial dysfunction, or is it the endothelial dysfunction that's leading to the hypertension? Those types of studies haven't been done with physically active individuals.
You wonder whether any of the epigenetic marks that are associated with exercise, and I know that there are epigenetic marks associated with exercise, become heritable.
Yeah, you know, the only argument I would have against that, though, David, is that if you, and Bill has shown similar data with the cardiac work, if you can take somebody who's been habitually physically inactive and over a short period of time improve these functions,
Excellent.
I think that would disassociate a genetic sort of component to it, and that it would put it on the outside of those barriers, that these adaptations can occur even in somebody who's been habitually sedentary for their whole life.
Excellent point. What about, Bill, you mentioned orthostatic hypotension as a function of increased stroke volume, essentially. And so what do you do for patients who complain of that?
Yeah, there are what we call preventative therapies, and then there are abortive things. So the easiest thing to do is flex large muscle groups if you start to feel lightheaded. I know it sounds a little silly, but it's very practical and it will help a lot of people. You can either stand up gradually, or if you stand up and you feel it, start flexing your thighs and your glutes. That forces a lot of fluid back into the vasculature, which increases venous return, and it will, after 10 seconds, not even that long, will make that go away. Drinking cold water, if it's available, will also help. 2 very quick practical things that you can do. For people who have chronic major issues, they may need medications and things such as that, but those are the 2 main things. We don't want to commit athletes or people in general to medications they don't need, when you can do those 2 simple things to very quickly alleviate orthostatic hypotension.
These were tremendous talks. Bill, tell us just in closing a little bit of how you get into the sports medicine clinic. And
sure. Yeah, we're accepting patients. If you have patients or know anyone, anybody, the easiest way, you can feel free to email me and we will get them in. We are advertising. We operate primarily out of the Cherry Creek Medical Center. But easiest way is just to shoot me a message either in basket or email, and we will get them taken care of.
Okay, great. Well, thanks very much for both of you. Really appreciate all the effort you put into this, and I've learned a lot from your talk. Thank you.
Thank you all.